The key to high reliability and good performance is leadership.
Welcome to the Operating System. I'm Andy Milkowski. This show is for healthcare operators who don't necessarily have time for theory. It's people running imaging centers, radiology departments, and health systems who want to know what's actually working at the highest levels from people who actually made it work. So my guest today is an industrial engineer who spent 40 years in over 100 hospitals, either as a consultant or as an executive. Not a typical healthcare resume. At Sarasota Hospital, he brought in discrete event simulation and started testing hospital designs before anybody poured concrete. At Kronos, he spent a decade putting labor management systems into 100 hospitals, and he'll tell you that software was never the point. At Catholic Health Initiatives, he ran productivity and clinical performance across multi-hospital division in some of the toughest markets in the country. And then at St. Elizabeth Healthcare in North Kentucky, as VP of Quality Operations, he took every one of the system's roughly 400 leaders through applied lean training and rebuilt the organization. How it looks at its own numbers. We will save what's happened out of those efforts to the end of the podcast. So, thank you for joining. We both have a similar background as industrial engineers, and this means we get to have a conversation that I usually don't get to have. Here's a question for you. Everything that you have applied is available to every radiology imaging center and hospital in the country for almost no money. Yet our observations are that hardly anybody does that. And if you walk into a hospital, can you tell whether it's been optimized?
Hey, Andy. Yeah, thanks for having me. I probably can. I know what to look for. You can tell if there's waiting rooms and they're full. And you can tell if they share data with you. You can tell if that data is sustainable and if they're meeting certain targets or benchmarks. So those are often things, as well as it's also very visible. I should be able to walk into a radiology department and see a huddle board that tells me that they're talking about their performance every day. And I should be able to see what actions they're taking. These things maybe they're in the break room, maybe they're in the middle of the hall. And you also probably just those visible cues that you see to help people with managing their resources. If they're not in a book somewhere, they should be out in the open.
So when most people talk about hospitals that don't work, they usually talk about either time or money. You're saying it's something else?
It's leadership. The key to high reliability and good performance is leadership.
Let's talk about that. Perhaps a good place to start is some of your experiences. I'll just talk about simulation, maybe at Sarasota or other hospitals. Please tell us a little bit about those experiences and what you mean then by leadership in this case.
Sure. A lot of times I was involved with simulation to help with some facility designs, and no one asked me about it. I just saw that they were looking at, we would be building things, and roughly 6 months later, the people in that area would ask for a construction change, and not a minor one. One area once had a pre-op and post-op area for a short stay, and they said it didn't work for them. So I got involved and I said, I think I can help you. One of the issues in our radiology suite, our director of radiology was saying he needed 4 R&F rooms. And the consulting architect asked if we could help them with simulating the volume in that room and how many R&F rooms they needed. But we didn't just simulate today. We simulated 6 years into the future. We said, well, we'll tell you what you'll need as far as your capacity. And while the architect and the director of radiology had been at a stalemate really for 6 months, in about 2 months, we were able to get this simulation together. We showed them that he still had ample capacity 6 years from now if they had built out the number of R&F rooms that the plan called for. And he turned to the architect in the middle of the meeting and said, I guess we don't need that extra room. And the architect was floored. I went on to do presentations at some architectural conferences with that architect because we did a lot of those types of projects to either validate the rules of thumb that often architects use, but also make some better operational decisions. Just one other example, we did some simulation in the cardiology suite, and they wanted to use the center of the heart lab for a viewing room. And we challenged that. We said, well, that's not optimal. They need supplies and they need supplies close to them, less waste. And we were able to show them through simulation that it's more efficient and we save some space to use that room like a center of the surrounding heart rooms. So a lot of times people just have an idea of what they want, but without really looking at data, looking at the future. And so because we don't know what the future holds, simulation is really one of the better ways to study a complex workflow and really document your assumptions. And then you can challenge those assumptions and make iterations.
It sounds good. Most people, when you mention simulation, probably don't know what that means.
Well, you're producing a model first around the way things work today. And you run numbers that validate, yeah, this is the turnover time. This is the number of patients that went through this area today. This is the service time. This is the wait time. You can compare that to your results today and say, okay, this model is validated. Then you can change things. You can add staff, you can add rooms, you can add volume, and you can say, okay, based on that, on a model that we know was accurate with today's information, how does it run? And when I say a model, I'm talking about a 2 or 3D model with patients walking in the door, doctors seeing them, nurses taking care of them, patients getting put on a stretcher, pushed out the door. A lot of different simulation packages have that level of visual cues that help you confirm, yes, that happened.
Let me push on that one a little bit more because I think there's an underappreciation to the level of absolute detail that you would get into in a simulation. Things like maybe walking speeds or exact arrival times over the course of the day. Speak to that a little bit more.
Yeah, the simulation packages are very sophisticated. And so it knows you can actually, I think it uses like 4 miles an hour if you're walking by yourself and 3 miles an hour if you're walking with a patient, or you can know the different things and you can put those things into it. I think though, the bigger question is you do need to talk about the level of detail, because if you try to simulate something to a gnat's eyelash, you'll take forever. And a lot of times you just need enough detail to get the answer you want in the direction you need to take. So it's not an accounting system. It's not going to be precise, but you do have a lot of things that you can model and you can take into account that gives you enough of a data table and metrics that you can say, this of the alternatives, this is the best one. We call them scenarios.
Perhaps you could illustrate other examples where that simulations or queuing theory has been used to improve service. McDonald's comes to mind, but that was a stereotypical example. I don't know if you want to share some of the details there, just so people kind of understand why these.
There's 2 workflows in everyday life people are going to be familiar with. If you go into Wendy's, you see that there's like one queue and you go through that. So people come in and the actual average wait is lower at Wendy's than it is in McDonald's that has multiple lines. You'll see it in the drive-through at McDonald's when there's someone takes your money first in window 1, and then you get your food in window 2, right? So let's say that each of those takes 30 seconds. That will take you a minute to get through there. But if they put it at one window, it would take you a minute at one window, and their throughput would be 1 customer per minute. But by splitting it in half and saying 30 seconds at one window and then 30 seconds at the second window, they're getting through a customer every 30 seconds. So they're doubling their speed. So that's one of the ways you can simulate that. But those are the queuing things you can test under simulation and try to improve on.
Are there any examples that you remember from hospitals, maybe CT or MR suites, in which there is such a queuing opportunity?
I'm thinking about right now about the ER and whether you have radiology equipment in the ER or not. I think it's obvious it's better to have it in the ER. But I'll tell you something that more impacts the waiting, and that is if you have standing orders or a way to identify early on if a patient needs a test. x-ray, lab tests, whatever. A lot of people have been putting either physician in triage or standing orders so that when the patient gets triaged, those orders go into place and you don't wait 20, 30 minutes to see the doctor and then he writes an order for those tests. We did a simulation where we actually put a doctor in triage and assumed he could tell what were the procedures. And we knew what percent of patients came in and needed x-rays or lab work or both or other things. And I think we found reduced utilization on the doctors on the back end because they didn't have to see the patient twice. And we also saw an increase in throughput. I want to guess, like, it's been a couple of years, but I think it was like 24% improvement in throughput. So it is significant what you can do and to understand the timing of things within a queue. What is a critical path when someone comes into an area and what things need to be done? And like when they move registration out of the front of the ER and now you get registered in the room, they knew that that was on the critical path, but it wasn't the critical thing necessarily to taking care of the patient. So some of that workflow, moving that around, can help with both the quality of the work and the efficiency.
And all of that is attributable in a lot of these cases to being able to do some simulations.
Yeah, well, simulation can help you. I look at simulation as we're going to be building something. It's a greenfield, or I want to fix something that's right here, and I have some different ideas, and you simulate your ideas. Simulation by itself is not going to say, "Oh, this is what you should do." And so, prior work with simulation helps to, when you go in, you mentioned, hey, how do you know if a hospital is optimized? Well, with that background, people with that background can go into a hospital and tell if, are the patients getting dressed in the room that they have this expensive radiology equipment, or is there a pre-op or ante room, a pre-op room that they are getting dressed? They go in the room only for the test and then they come out and get dressed. That makes the use of that room much more efficient. And because it's such a costly piece of equipment, you don't want to have multiple versions of it if you don't have to.
Right. Is the act of doing some simulations, test theories, rearrange your equipment, is that expensive to do that? I know you talked about there's different levels. You only do it to the level that you need to answer the questions, but how does that compare to doing the rest of the project?
Well, often these things can be 30 to 130 million innovations, like adding a wing or a hospital or a critical care tower or whatever. And I've seen good software around 20 grand. And you can contract out to people to do the simulations if you don't have the expertise, but they can do it within a month, maybe two. And you gather the data. A lot of this data is readily available. You have time-stamped data in the hospital of when the patient arrived, when their orders were taken, when they discharged, so a lot of that's readily available. So I think it's relatively inexpensive, and especially compared to the cost of making a mistake.
Yeah. So you're talking about, if you're talking about months and tens of thousands for software, you're talking about like a very small, very, very small fraction of 1% on the of a project cost just to get nice results. I know that another concept related is that many places try to, in their backlog, attempt to push more, try to cram their schedule just fuller and fuller until just to make up some backlog. And there's a risk with that.
Everyone's got this story and I'm thinking about the OR where the doctor told him to be there at 6 o'clock and they have a noon scheduled procedure, but he doesn't know necessarily the order of things. And the patient, that's not good for the patients. Their expectation is that they're going to be there. They're at a scheduled time and they're going to be there to be taken care of. So I think you run the risk of a poor patient experience when you can't predict, your operations enough to tell the patient what time they should be coming to the.
Before I pivot to Kronos, I want to go back to that Wendy's single queue versus McDonald's example. Why did the Wendy's go faster?
Well, it's the measure you're using is the average waiting time. So when you have one queue, the average waiting time, it's first in, first out, right? So, but with a McDonald's, you may be the first in, but you may be waiting because someone else came in and got taken care of before you did. So your waiting time is a little bit, maybe a little longer. So the average of all those people who do it that way, with say there's four counters, workstations, your chance of waiting is usually longer than if you went through a one single queue.
Well, I was thinking about the different queuings where banks used to have the for cash deposits only line or the 10 items or less line as one way of managing a queue as well.
Yeah, those are effective.
Everybody thinks about that as a time software. I think your experience was Albany and Kronos. Perhaps you could
Oh
tell us a
yeah.
little about
So
it.
yeah, I was working for a health system. I want to say they had 23 hospitals across the eastern side of the United States. And we were implementing our productivity labor management solution. And I worked for Kronos for about 10 years. And anyway, this client was very happy with what they were getting. And they turned to us and said, well, can you help us with this problem we have up in Albany, New York? We have a radiology department that isn't meeting its labor benchmark. And so this wasn't something Kronos necessarily advertised or did, but being consultants, and I call it trusted advisors in our role there, we said we'd be happy to try to help. And so we went up there, we looked at the data, we're familiar with benchmarking comparisons, and it did look like they were comparing them to the wrong set of benchmarks, which helped their case. But secondarily, we looked further at their operations, and they were running just a first shift operation. And so you can imagine shutting down at 3:00 every day and everybody waiting till tomorrow to get your radiology procedure. So we suggested a second shift. We used linear programming. We used linear programming to identify the optimal number of 8, 10, and 12-hour shifts you need to cover the workload. That kind of approach is optimal to any type of schedule you have if you have the right data. And it did show, we need to put a second shift in or a staggered shift that went later into the day so that they didn't have to do those procedures tomorrow.
What were the indications to you that when you were looking at that would give you, or somebody listening to this, that would give them the indication that perhaps it's a staggered extended shift issue rather than some other problem inside the shift?
Well, we took timestamp data. We knew what time every patient came for every modality. And for each modality, we did a staffing analysis. But we actually identified the demand by hour of the day. And we saw the orders that were coming in later in the day that were taking longer. They either weren't getting done or they were taking longer to get done so what you do is you look at your workload. So you count, basically is the room used or not? If you have 4 imaging rooms, you just say, how often is that room used in that hour? So if you have 6 months, 180 days, and you do weekend versus weekday, you say, okay, this is how many days that room was used, and you figure out the utilization. And then you try to say, well, to improve it, some of them were very, very high. So we would put the demand higher at those times. And we knew we used the standard. They said, if we do this procedure, we get, 20 minutes to do that or whatever. So we were able to model their workload on a graph. And we knew if they came in at 10 and they were there till noon, that they were still there when the next patient came in. So we were able to stack it and say, okay, based on that, here's a picture of the workload. This is what we need to cover. We have enough body to cover this workload.
Your example reminds me of, I think, some papers that I read about labor and delivery and having all the first shift employees go home and then the expectant mothers arrive after the work.
Yeah. You got it, you're trying to meet the demand to the time it comes in. One of the leaders of our quality improvement department had worked in a hospital, and he had done some work at St. Elizabeth to help them to plan out the number of patients that would come in for birth by looking back at the schedule in our OB offices 9 months before. So they could tell generally what the workload would be But at the same time, they would work with those patients to make sure they, they had all their visits, they had all the prenatal care that they needed, and they were scheduled. They had a general idea what week they were expected to see them, and then they would make sure they would have staff. Someone told me September is the highest month of the year for babies, so just knowing some of that, it can help with planning out the need you have for resources.
You remind me of another one about all of the heart attacks that happen when we change our clocks by an hour every year. Similar story. They're predictable events. And in this case, you're predicting the events of delivering babies and staffing accordingly. That's fantastic.
No, I was going to say, even something like the emergency rooms have very predictable volumes. If you start looking at weekends, have a different workload than weekdays, and, you know, time of day is common, so there's very, very predictable patterns.
So let's pivot again. And perhaps yes, your St. Elizabeth and maybe the whole five-star experience, five-star hospital kind of experience, and what you learned there. I think because that's a very holistic look at everything that you've accumulated, all the knowledge that you've accumulated over your working career.
Yeah, that was really my last role before I retired. I was there for 9.5 years. Early on, partnering in a dyad with a physician there, we were in charge of the quality function. And the challenge to us was, how are you going to improve our quality? We went on a journey. A lot of credit goes to organizations that came before us, ThedaCare in Appleton, Wisconsin, and Virginia Mason, who adopted some lean principles. I had some experience with some of the Quint Studer leadership expectations and principles. And so we created our own transformation of our hospitals. There's 5 hospitals within the St. Elizabeth healthcare system. And one of the things I can share at the end of our journey there in my last year, 3 of our 4 hospitals that were eligible for CMS ratings are 5-star hospitals, which means they're in the top 12% in the nation. In the U.S. News and World Report that came out in the last 3 years, St. Elizabeth Edgewood, their flagship hospital, was number 1 in Kentucky. And that's been the case for the last 2 or 3 years. And today it was just announced by U.S. News and World Report that they're number 1 in Kentucky again, and they're number 1 in Cincinnati. So we were always number 2 in Cincinnati. Cincinnati is a very competitive marketplace and got some really good healthcare. But if our hospital was in Ohio, it would have ranked number 2 behind the Cleveland Clinic this year. So a lot of that is through the transformation, the leadership I mentioned earlier. The answer to this is leadership. It's getting leaders on board and we put in 7 leadership practices. We call them evidence-based practices. Things like rounding on your staff and rounding on your patients, using standard work and validating that standard work is in place and happening. We had huddles, and we evolved those into tiered huddles. Recognition was also another one of those things. So we actually would monitor how many recognitions leaders were giving, how many rounds they were taking, and we would look to see that they were all following our leadership expectations. And every quarter, we would have outside speakers come to a day-long session on that we would bring to our leaders around here is what other organizations that are highly reliable are doing. We even brought in outside speakers like pilots from the Blue Angels that talked about how they can fly so fast, inches from each other. What's it take? What kind of practice does that take in order to be that good? And so a lot of leadership development. We really focused on those things that move the needle. And I mentioned earlier, education, yes, but it wasn't voluntary education. We were looking at what you learned today. We were going to ask you to produce output based on that, share with your leader, and we were going to monitor and expect that to be the new norm. And just building on that, quarter after quarter for 8 years, we built in a highly reliable system with people following. I had a leader from another organization call me once me and my physician said, "Hey, I just was at your hospital and I work in the hospitals and I can tell that you guys are doing something different. I could see that people were following processes and it wasn't random." And anyway, that was someone who could tell because he knows what core processes produce.
So let's put a little more detail behind it. You mentioned education was big. What type of education, if you could?
Yeah. Well, we actually certified our leaders. It was required within 6 months of being hired that you went through 4 classes. The first was your orientation, where you got a 1 hour summary of quality and some of the early, like what is waste and what is standard work as a leader. And that you were expected to be attending huddles and leading huddles and also implementing standard work. Then we had another session. It was a computer-based module about what are those 7 leadership practices that we all want to practice and your role as a leader in it. We called it our Journey to Excellence, JTE. Then we had a class on applied lean for leaders. And we took them through a day-long class on what performance is, difference between outcomes and process measures. We took them through visual management, doing 5S and standard work. And all those had exercises. We actually had to fold t-shirts in a standard way. We looked to see whose t-shirts were folded and was it done in a timely manner. So we had this workshop, and then the fourth one was how to do a A3 problem solving. So that was basically using a problem solving format that would allow you to communicate with others about how you see the problem, what data you have, what is your solutions, what have you tried, and what's the result. So those were, and if you did those 4 classes, you got a pin that said you were a quality leader. And so we did all 400. And of course, you have a lot of turnover in 8 years. So we were doing a class every quarter. That was the main education that we provided, that gave everyone the common language, a common approach, and in how we resolve issues. And so we really turned into a community of continuous improvement leaders, and constant change.
You mentioned
The norm. It can look like chaos to some, but if you know what you're doing, you know that it's a lot of change. And people would say, "When are we going to be done changing?" And like, we're not going to be done because you need to stop.
wow. You mentioned, I think in that article that you wrote, is radical transparency was
Yes.
part of the initiative there.
One of the first things we started with was huddles. And we put the first huddle board on a nursing unit and we put it in the hallway. And nurses, they would have 2 huddles a day, the 7 a.m. shift start and the 7 p.m. shift start. And they were tracking things like their falls or their pressure injuries or their infections, as well as like how fast they were responding to patients who had call lights. I'll never forget this. I went up to see the huddle board and there was an F on the board and a check mark. I said, "What does this F mean?" And they said, "Well, that's a fall." But we didn't want to write fall because everyone's going to come by here and see that. And we said, "Well, that's okay. They're going to know that you're working on it." And then from that, we just expanded. We would show patient experience scores by unit in our leadership meetings. And we would even rank them. So the best to the lowest. And if no one wanted to be at the bottom, sometimes we'd ask them, "What are you doing that to help correct your scores?" We did it by facility. We would have, here's our mortality rate at this hospital by hospital, and look at is our processes evenly distributed across all the facilities. So
how did you manage kind of idea generation and huddles? Was there a process for that? Ways of people kind of prioritizing their ideas?
yeah, the huddle boards themselves, and I would like to see them even more utilized than we had them. There's a spot at the bottom that was to do, doing, and done. And little Post-it notes you could put up, say someone had an idea, they could write it on there, put it on the to do, and the next time they have a huddle, the leader can see if there's confirmation. Does everyone else think this is a problem? If you did find there was a problem, then you might move over to who will volunteer to work on this. And if you get a volunteer, you put it in the doing. If you don't get a volunteer, it stays in the to do. And then once they get it done, they report back what they've done. It goes in the done box. And so this is a good way for leaders to sort of delegate work that comes up and not feel like they have to do it themselves. It's a way to say, hey, if I can't find someone who agrees this is a problem or willing to take it on, then it's not a big enough problem for my staff. So there's tools like that on the huddle board. We manage larger projects based on surveillance of our data and our quality. Overall, we had an overall quality improvement committee. We would say, oh, we need to do a project on readmissions. And so we would get one of our lean Six Sigma black belts who would facilitate, the frontline staff in determining what's the issue and how do we solve that issue.
I know you went through a lot of training, so everybody's inherently biased towards doing change, right? What's the rate of implementing ideas? Is there a metric that you kept for that? Or how big is that number of changes that you've done?
We just had recently implemented a system-wide employee involvement or idea program online. And that was last year. It generated 400 ideas in a matter of 2 months. And they're currently working through that. I have a history with employee suggestion programs. I've implemented them in 2 or 3 hospitals. Generally, you have about 20% of all the ideas that come in. When I was at Sarasota Memorial for better part of 15 years, toward the end, we were saving $1 million a year from employee ideas. And those ideas were budgeted every year. That's how reliable it was. Those things are very touchy because you have to be responsive to employees. You have to take their ideas seriously. You have to meet them halfway. Say, hey, this is the generation of your idea, but with this change, it will probably work. And most employees are okay with that. But that takes a lot of work. And, again, what's the expectation on our leaders in listening to their frontline staff?
Did you just say that you were able to reduce operational costs by like $1 million a year?
A lot of it's supply costs, OR preference items,
And this is
Yeah.
cumulative. You saved $1 million.
No, yes, each year you're saving $1 million. I'd calculated somewhat like over the 15 years. I ran that program for 12 years. I think I was over $20 million cumulatively.
Wow. Very good. And obviously, these things that you talked about, 7 principles, huddles, and that, obviously had an impact because you started this whole piece with the fact that St. Elizabeth was now being ranked number 1 in areas. Let's pivot. Let's close with maybe a set of rapid fire questions.
Okay.
One book every healthcare operator should read.
Operating on the Mend by John Toussaint.
Reason for that?
Well, it's their story of how they transformed their organization. And he is a physician and he got a lot of physicians involved. And so I made it a book club reading for our senior leaders and handed it to many physicians. And it really sort of explains it, I think, from a clinician standpoint, why you need to do this. There were doctors who have their own practices and someone would come in and show them how they could be more efficient and not spend all their charting at the end of the day or not back charts in the ER and things like that. I think it helped people to understand where we were going, the kind of transformation that we wanted. And Theta Care also, who John Toussaint was over Theta Care at the time, they had reached several accolades themselves in their quality and their operations.
So perhaps you can remember, what about a rule of thumb in healthcare design that should have died years ago?
Well, the one that comes to mind was just from my simulation time is 2 recovery beds for every OR suite. Used to talk with architects about that, and, it matters whether you're doing cataract surgery or you're doing open heart surgery to how many recovery beds you need. So, simulation was one example of trying to figure out how big of space you need for different things. So, and I'd say architects I talked with, they knew that. They knew they didn't have anything better. So they embraced a lot of the science that engineers like myself could bring.
Cheapest change, maybe out of all those ideas, that you've ever seen produce a real number, a real result?
I'm going to take something that just had a good impact. It was in the ER, and our leave without being seen rate was approaching 5% in one of our St. Elizabeth hospitals. And they did not use what many people may hear of as fast track or a split flow where you're taking people who rank as what's called a ESI 4 or 5, level 4 or 5 at least. That means you probably don't need labs, you don't need radiology, you just need a doctor to see you, maybe stitches, maybe a prescription. And so without a split flow, those people are getting put in with everyone else. And when they wait more than 25 minutes, they will leave. That's our leave without being seen. So you take 5% on thousands of ER visits, it's very, very costly. And the reputation in your community is don't go to that ER. So we took a supply closet, put 2 recliner chairs in there. We took a consulting room, put 2 recliner chairs in there. We had one of the doctors come over and staff that. And then we put rules at triage that if they were these certain categories of patients, send them over to, we didn't call it fast track, we called it minor care. Okay, this is the minor care, not, that the care was minor, but it was less acute. And we got the leave without being seen went down to under 2%, close to 1%.
And no staffing changes.
Just moved them,
No
just moved the staff, did a different workflow. And it's something I had used and adopted everywhere else, and they had never adopted it up here.
And this goes right back to the cash only 10 items or less kind of queuing methods.
Yeah.
What about somebody listening, somebody involved in the radiology department listening? What do you think they should do tomorrow morning after listening to this podcast?
I would say read the book On the Mend if you haven't. And I would say try to implement some of those things. Now, if you're a leader of your area, you can control that area. You can't control the rest of the organization, but you probably can do a huddle. There's probably YouTubes that show you excellent huddle examples. Haven't done one, or if you're doing one, you don't think it's effective, there's videos that can help you with that. And I would say those are the 2 biggest things I think you can do to just kind of get the ball rolling. What other people might suggest is doing a 5S, which is, before every shift, make sure everything's back in its place for the next shift, which I think is a good way to just start everyone off on a good foot. And, par levels are where they need to be. I'd say the other, read the book. It's got a lot of examples in it, but also make sure you have a very effective huddle. And if you're clinical and seeing patients, you should be huddling every day. If you're a support area, maybe once a week is fine. But that's my suggestion.
Awesome. Thank you. So Jim, for folks that want to connect with you or perhaps read the piece you wrote about how Elizabeth got there, where should they go?
Article I wrote around our CMS 5-star journey and our journey to excellence at St. Elizabeth, that is posted on my LinkedIn account, Jim McCarville on LinkedIn. And I can make it available, Andy, to you if you have a place somewhere else to post it or put it to this podcast.
Please do.
Okay.
Excellent. So Jim, I want to name what I really liked and what made this podcast a little different. You gave us tools and mechanisms, not just a summary of results. I think a lot of people can take away those tools and hear how you implemented them and perhaps mimic some of those behaviors. You talked about the kind of math behind the 2 windows in a drive-through or the minor care in a supply closet, right? Many people connect on these and do very similar things without an additional vendor, without additional budget cycle, and without a new CT counting photons, right? So it's the reason I think you're attributing to the 5-star hospital ratings.
One of the things that I've discovered, and it really kind of went against my initial training as an engineer, is some of the lean principles that I learned, because I was, I thought, hey, batching is good, right? You're more efficient, but it's bad. You got to do one at a time processing. And so lean is about using less technology, making changes that you have with resources you already have, and just doing it in a different way. Relying on your frontline staff more than senior management dictates is what lean is all about.
So to everybody else listening, if you got something out of this, subscribe to the operating system wherever you listen, and send this one to someone about to sign off on a new construction drawing or staffing benchmark that they haven't questioned before. I'm Andy Milkowski. This is the operating system. See you next time.